You are about to view the video segment for Module 1, When People Fall, Prevention for Those at Risk. It portrays a complete approach to preventing falls among the elderly. Falls present a significant health threat to older adults, affecting their health and quality of life. Preventing falls and injuries is a challenge that requires physical therapy, restorative care, self-care, and activities and exercise. Physical therapy is a very important means of restoring mobility and can assist the resident to gain mobility skills. Restorative nursing is critical in helping the resident maintain strength and continue to improve in function. In addition, encouraging and helping residents to be as independent as possible is a critical part of an individualized care plan. Activities and recreation programs are also part of the fitness plan. Walking and exercise programs, often provided by the nursing assistant, promote mobility in a natural manner. The nursing assistant is a key team member in assisting the resident to remain as mobile as possible and helping the resident with his or her individualized fitness plan. Let's review the components of such a plan. The physical therapist and other healthcare practitioners provide assessment, the first step in developing an individualized fitness plan. The therapist assesses the resident's range of motion, motor strength, coordination, position sense, vision, sensation, balance, use of an assistive device, gait, and the ability to rise from a chair and begin to walk. The physical therapist also teaches the resident important safety techniques and bathroom safety measures, such as how to use grab bars and how to use the call light for nursing assistance. The physical therapist, nursing assistant, and resident, together with other staff, develop a plan to help the resident regain and maintain mobility. Individual restorative plans are effective in promoting function when there is follow-through on a 24-hour basis. Individual treatment plans for exercise and gait training need to include walking to and from meals, the bathroom, and activity areas, transfers to alternate seating, remembering to lock the wheelchair brakes. Most wheelchairs are designed for transport but not prolonged sitting. Helping the resident move to a more comfortable chair will increase leg strength and also prevent falls due to sliding and poor posture. Resident involvement in self-care, including eating, dressing, and bathing. Involvement in individual and group pursuits. Range of motion exercises if indicated. Activity programs are also valuable in promoting fitness and mobility. Recreation encourages socialization and increased self-esteem to prevent depression and anxiety, both risk factors for falls. Activity programs also provide an organized means of support and supervision to residents who are at risk for falls. In addition, activities can provide a fitness component that supports restorative and rehabilitation goals. Exercise programs provide increased mobility and strength, socialization, and fun. Walking programs. Residents who have similar strength walk on a consistent basis, providing a natural way to exercise. A social component such as a sing-along may be added. Dancing and movement programs also encourage range of motion. Yoga and Tai Chi improve flexibility and balance. Active games can be adapted to the resident's physical and cognitive abilities. Some activities promote fine motor skills and range of motion. Examples include gardening, arts and crafts, food preparation, and baking. These activities also promote range of motion, trunk strengthening, and balance. An activity plan that reflects the resident's preferences and choices not only makes life interesting, but also provides opportunities for exercise and strengthening. Successful fall risk reduction requires physical therapy and occupational therapy for rehabilitation, individualized restorative care and promoting self-care, meaningful activities and exercise targeted to the resident's goals and capabilities. In addition to reducing falls and injuries, the benefits are improved function, decreased fall risk, and overall quality of life for the resident. For the nursing assistant, the benefits are increased job satisfaction and enhanced relationships with the residents. This concludes the video segment for Module 1, When People Fall, Prevention for Those at Risk. You are about to view video segments for Module 3, When Wrong Things Happen with Medication, Risk and Prevention.
Good morning, Mrs. Sager. It's Becky, the night shift nurse.
Good morning.
I'm here to give you your insulin this morning. How did you sleep last night?
Good.
That's good. Okay, this will only take a minute. Looks like it's going to be a really nice day out
that's
today.
nice.
Becky, the night shift nurse, prepares to give Mrs. Sager her morning Humalog insulin dose at 7 a.m. Becky has consistently cared for Mrs. Sager since she was admitted 1 year ago.
There we go. And as soon as I give a report to Betty, she'll be in to get you up and get you ready for breakfast, okay?
Thank you.
You have a good day.
The principles of safe medication administration are: give the right drug, in the right dose, to the right person, via the right route, at the right time. Despite staff knowledge of these principles, in the hustle and bustle of everyday life in the nursing home, almost anything can and will go wrong. Gwen is the only healthcare provider on the floor, and she's doing the morning medication pass at 7:45 a.m.
Morning, Mrs. Sager.
She talked with me.
Ready for breakfast?
Oh, yes.
We'll be serving breakfast in about 15 minutes.
Taught the same in middle school.
Good morning, Mr. Christman. I have medications for you, sir.
Thank you.
Nurse, we need help here. Mrs. Sager.
Natalie, please call your office.
Mrs. Sager, are you
Natalie,
okay?
please call your office. Thank
I
you.
knew she was here.
Mrs.
I
Sager,
knew she was here.
did you see what happened?
No, I didn't. Fairly newcomers.
Griselle, I need your help. Mrs. Sager?
Can you spot all the errors? Please take a moment to discuss the errors that you've seen. Did you catch the first mishap? While the nurse was checking Mrs. Sager, she left the medication cart unattended. This gave another resident the opportunity to sneak something off the cart. What about the second mistake? Again, while the nurse was tending to Mrs. Sager, another resident took advantage of the confusion and discarded his pills in the bird cage. What could have been done to prevent these errors? Part of this facility's monthly quality improvement meeting will focus on adverse drug events. Each team member, in this case a nurse, pharmacist, administrator, and CNA, plays a key role in the problem-solving process. Let's join the meeting for the portion discussing what happened with Mrs. Sager.
I would like to thank everyone for coming to this month's quality improvement meeting. We have had quite a few medication errors in our facility that need to be addressed and resolved. I brought in our pharmacist, Bob, who could maybe give us some input on how to correct these medication errors.
Yes. Well, we'll start with an incident that occurred 2 weeks ago involving Mrs. Sager on the first floor. I see that this is the third time that she became unresponsive and was found to have low blood sugars. She is getting Humalog insulin 8 units in the morning.
Dr. Miller has been reducing Mrs. Sager's insulin dosage, but she continues to have the hypoglycemic episodes.
Well, what time are you giving the insulin to Mrs. Sager?
Mrs. Sager is given her insulin by the night shift nurse at 7 a.m. just prior to our morning meeting.
Well, now it needs to be given within 15 minutes of her breakfast. What time's breakfast, sir?
Oh, there's our problem. We don't serve breakfast until 8 a.m.
That is the problem. Yes, indeed.
Are you saying that we need to have Mrs. Sager receive her breakfast and closer to time of her insulin administration?
Yes, it should be given. The insulin should be given 15 minutes before breakfast.
Could you help us out with that?
I think I have a solution to this. We can contact the dietitian and the morning cook tomorrow morning, arrange for the diabetic trays to come up 7:15 every morning, and the regular trays can still come up at 8 o'clock. And that should really reduce the problems there.
That should solve the problem, yes.
Okay, we'll get on that tomorrow morning.
And what do you feel about that, Griselle?
That's a great idea. Tomorrow afternoon we'll have a meeting around 2 p.m. and we can address the changes.
Okay, I'll make sure I'm there so that every CNA and every nurse is made aware for both night shift and the morning shift so that we can reduce these problems, reduce the doctor's calls, and lower our medication errors.
Very good.
Okay, great.
Be good not to have any more emergencies such as the one with Mrs. Sager.
Yes.
This concludes the video segment for Module 3, When Wrong Things Happen with Medication, Risk and Prevention. This video segment for Module 4, When the Mind Fails, Cognitive Losses in Dementia, shows a patient with many of the cognitive deficits you are learning about. The patient is being helped by several staff members. At the beginning, a nurse asked the facility's dietitian, Anne, to check on Miss Adams, a patient who has been eating less and losing weight.
Anne, I've been meaning to speak to you about Mrs. Adams. She's really losing weight and refusing to eat, and her appetite's become very poor. Could you take a look in on her later?
Yeah, maybe I could go stop by at lunchtime and see how she's doing.
Oh, great.
Okay.
Thanks a lot.
Thank you. Hi, Mrs. Adams. How come you're not sitting down at the table? Don't you want to have something to eat?
Oh, I'm just fine, dear.
I know, but you haven't had your lunch yet.
I haven't?
No, you had breakfast this morning, but now look, it's lunchtime already. Let's go in and have some lunch now.
The dietitian was primed to think that this is a problem with Miss Adams's appetite. In fact, Miss Adams can't remember whether or not she ate lunch today.
Okay, Mrs. Adams, enjoy your lunch, and I'll be back later to see how you're doing.
Miss Adams needs a simple cue at mealtime to remind her that it's time to eat again. With this support, she makes a good effort to eat. This tells us that the problem is loss of memory, not loss of appetite. You can compensate for memory problems or amnesia with simple cues and reminders. Although Miss Adams is still able to pick up a glass, her dementia leaves her unable to recognize what ice cubes are, and she can't figure out the purpose of the glass or the ice.
Let me help you, Ms. Adams. I'll fill up with some lemonade. Okay, there you go. You gonna take a few sips? Okay. Let's take a sip, see if you like it.
Miss Adams needs help to compensate for her impaired ability to recognize familiar objects. With a little nonverbal guidance, she's able to hold the glass and drink, and her functional level is improved. You can compensate for recognition problems or agnosia by demonstrating how to use objects.
Ooh. No, you don't like it? Maybe another sip?
No. Miss Adams can still handle a glass and drink with a little assistance, but now she doesn't want to drink the lemonade that was offered. Miss Adams expresses her displeasure through facial expression and gestures, but she can't say exactly what she wants. This illustrates how aphasia or impaired speech can interfere with function and even lead to poor fluid intake.
I see you don't like lemonade. Would you like milk? Or coffee? How about some tea? Okay, let's try the tea and see how that goes.
By trying different nonverbal approaches, the patient can be helped to express her preferences. Because of her language problem, she can't say what beverage she would like, nor can she respond to the names of the beverages when the aide gives her a choice. In this case, her aide had to offer her a taste of tea to find out her preference. Now she's more likely to keep up with the fluids and avoid dehydration. You can compensate for language problems or aphasia by using nonverbal communication.
Oh, Miss Adams, you didn't eat much off your tray. You must not be hungry, but you sure made a mess. Let me get this cleaned up a little bit. Okay, let's try it with a spoon. Okay? Try this right here. Okay, in the custard? No? Okay, let's see what else you want to eat. Let's try this. Did that work out? Good. Great.
Miss Adams has apraxia and is no longer able to manipulate a spoon, so she can't use utensils to feed herself. However, when offered finger foods, she's able to eat without assistance. Her oral intake is better, and she appears more content. You can compensate for problems with motor tasks or apraxia by simplifying tasks. Finger foods eliminate the need for utensils. Another example is when we use Velcro for the patient who can no longer tie their shoes, button buttons, or zip zippers.
Okay, all right, let's spit some out. Spit some out of your mouth. Okay, all right, good. Now swallow whatever's left. Okay.
Miss Adams can still swallow, but she has trouble coordinating chewing movements. We call this an oral apraxia. If she is coached to take small bites and is given repeated cues to swallow, we avoid having her mouth overstuffed and reduce the risk of choking or aspiration. If we recognize problems with memory, recognition, languages, and performance of motor tasks in our patients with dementia, we can assist them in ways that improve function and reduce dependency, allowing them to do more for themselves. Our illustration today shows how this can be important for activities of daily living such as feeding and for maintaining nutrition and hydration. Helping patients to use their remaining skills can also increase their sense of satisfaction as well as their quality of life. This concludes the video segment for Module 4, When the Mind Fails, Cognitive Losses in Dementia. You are about to view video segments for Module 5, When Behavior Challenges, Responding to Behaviors Associated with Cognitive Loss. The first scene is about wandering behavior. When they lose language skills, persons with dementia still communicate their needs and feelings using behavior rather than words. Finding the message in behavior requires careful observation and assessment. Behavior that is seen as inappropriate or troublesome is most often the result of a person trying to meet his needs in familiar ways. The following scenario is common in nursing facilities. Mr. Adams is a 75-year-old resident admitted 1 year ago. Mr. Adams had worked 45 years as a retail manager. His interests included hiking in national parks and friendly visiting to shut-in and hospitalized members of his religious community. Mrs. Smith is a fiercely private resident who enjoys her solitude. To protect against uninvited guests, she has agreed to a stop sign across her doorway.
Who are you? Go! Get out! Go away! Go! Nurse! Nurse! There's someone in my room! Go now! Go!
What needs were being expressed by Mr. Adams? If you were the staff member who responded to the call for help, what would you do first? Second? How might repeat episodes be prevented? Merely labeling Mr. Adams's behavior as wandering would overlook the needs he's expressing and attempting to meet by walking around. These include needs for expressing normal curiosity, for sensory stimulation and relief from boredom, for companionship and social interaction, and for normalcy and old role behaviors including meaningful work. Once we have these understandings, Mr. Adams can be helped to meet his needs in ways that do not impinge on the privacy of others in the environment. This concludes the first scene. This scene of the Module 5 video segment deals with aggressive behavior and resistance to care. Providing personal care to those with dementia is often complicated by behaviors that may look like resistance or aggression. Caregivers are hard-pressed to understand the person's behavior when it interferes with getting the shift's work done. The following scenario is not uncommon in today's nursing facility. It is now late morning, and Miss Stark has saved Mr. Soblinski's shower till last. He's seldom pleasant or cooperative, and in fact has been known to hit and kick when the CNAs try to provide his personal care. In addition to dementia, Mr. Soblinski also suffers from painful diabetes-related nerve damage to his feet and legs, and is now unable to walk unassisted.
All right, it's shower time.
Go to hell, you bitch!
Oh, Mr. Sablinski, it's just your shower.
Oh, no. Put me back.
Just
Stop.
a few minutes,
Now,
okay?
put-
Just a few minutes. All right, Janine, I need you and the nurse. Mr. Sablinski's gone off again. Janine, now.
Taken by surprise when Miss Stark approached him suddenly from the rear, Mr. Soblinski is now attempting to regain control and protect himself from possible harm. How did Miss Stark's knowledge of or past experience with Mr. Soblinski influence her behavior today? What are likely some of the contributing factors to Mr. Soblinski's response? What was he attempting to communicate by his behavior? What approaches would you recommend to Miss Stark that may prevent a similar response from Mr. Soblinski in the future? All behavior is meaningful. When behavior appears to be aggressive or resistive, often the first response from caregivers is to exert control. When such behavior is viewed as communicating a need for self-protection, however, many preventive actions become apparent. These may involve such simple things as approaching the person from the front, avoiding actions that may startle, simplifying tasks and instructions, giving the person some choice, using a calm voice, and smiling. Each of these have been shown to help the elder feel more secure and also produce greater cooperation with caregiving. This concludes the second scene. This scene of the Module 5 video segment deals with noise-making and repetitive vocalization. Verbal repetitiveness is fairly common among persons with dementia. This behavior may reflect losses in memory and cognitive functioning and may communicate unmet needs. Repeating words or phrases occurs more when persons have a hearing loss, when they are isolated, lonely, worried about personal safety and well-being, or when in pain or tired. Hearing the same question over and over, however, can make an already tired caregiver feel exasperated. The caregiver's response may then fail to recognize and meet the person's needs. This is portrayed in the following scenario. It is 5 p.m. on a gray winter day in the nursing facility. After spending his afternoon sitting in the common room and walking in the corridors, Mr. Jackson has been watching people coming and going during change of shift. The staff are now busy with medications and treatments and preparing for the evening meal. Family visitors are arriving as the daylight dwindles. Room and hallway lights are just now coming on. The view through the window reveals a steady stream of traffic, headlights beaming, as people go home at the end of the day. Miss Johnson is thinking about what lies ahead. 2 CNAs have called out sick, and her workload is nearly doubled for the evening. She knows Mr. Jackson well, as he's been part of her assignment many times.
Do they have a room for me?
Why are you asking that question? We go through this every day. It's right down the hall.
But do they have a room? Where will I sleep?
Don't get on that again. I'm not even going to answer.
Please find me a room. I'm so tired. I need a place to sleep. Please, don't make me leave.
What does Miss Johnson think is going on? What is contributing to her frustration with Mr. Jackson's questions? What needs does Mr. Jackson communicate by his behavior? What could Miss Johnson do now to relieve Mr. Jackson's anxiety? Knowing that this same pattern of behavior is repeated nearly every evening at about this time, what individualized intervention could be put into place to better meet Mr. Jackson's needs every day? What can she do to take care of her own feelings? Repetitive vocalization provides clues about a person's needs that may be easily overlooked or dismissed. Identifying patterns, triggers, and possible meanings will be helpful in planning individualized care. This concludes the video segment for Module 5, When Behavior Challenges, Responding to Behaviors Associated with Cognitive Loss. You are about to view a video segment for Module 6 on palliative care. Palliative care is active, total care focused on improving the quality of life for persons with progressive, far advanced disease for which the prognosis is limited. All disciplines collaborate to provide advanced care planning, physical and emotional comfort, and social, bereavement, and spiritual support. Some nursing homes communicate these end-of-life issues at daily rounds and care plan meetings. The following depicts a palliative care team meeting as is held weekly at the Pines, a Genesis elder care facility in Easton, Maryland.
Today we're going to talk about Agnes Talbot, who was recently admitted to the Pines about 15 days ago. She's an 87-year-old lady that came in with dementia, agitated features, diabetes, and peripheral neuropathy. Her husband has not been able to take care of her at home because of her recent decline in status. He's noticed that she's now become incontinent. She's not able to walk as well, she's not sleeping at night, and she's not eating as well. He is also noticing that now that she's not able to recognize him, she becomes more combative, and he thinks that she's also having more pain. We feel that this is probably related to her diabetes.
I'm really surprised that Mrs. Talbot has done as well as she has with her husband taking care of her by himself. He certainly seems to have tried his best and must be really exhausted. Constant pain she's having from her diabetic neuropathy is making her more agitated and more confused. She can't express her needs and has become more and more uncooperative. I'm sure she'll benefit from our pain management program in the future. Her poor appetite and erratic intake of food has kept her diabetes out of control. And renal failure is getting worse and she's at risk for skin breakdown.
Okay, I did do a spiritual assessment with the family. Both Mr. and Mrs. Talbot were very involved in their church for many years. They led prayer meetings and brought food for the special services and were part of the choir. Reverend Krause was involved with them in the community and has continued to visit her here while she's been at the facility.
I will talk to Mr. Talbot when he comes in, hoping that he'll bring us some music that she's familiar with and maybe bring some snacks that she likes to have because they used to do the prayer meeting groups.
With Ms. Talbot's declining condition, weight loss is expected due to poor appetite. Her advance directives indicate no aggressive measures to be taken.
And she's not eating as much as she used to, so I think she's lost some weight. But when I do try to weigh her, she becomes very upset with me.
I think the suggestion that Sheila made is very important, that maybe discontinuation of the weights is not only going to be something that promotes her dignity, but also is something that we know the weight is going to change over time. It's an expected decline, and that is one less stressor that her husband will have to deal with. Because she's having some behavior issues, it may be resulting from the pain that she's been having from her neuropathy. Are you seeing anything else legally that says that her behaviors are indicative of more pain?
Yeah, she moans a lot when I washes her feet, and she kicks me, telling me that her feet are on fire like pins and needles. And I'm afraid that her skin will break down if she won't let me wash her.
Before we stated that the neuropathy is a likely cause for her pain, and Dr. Crowley has started her on some Neurontin for that. We may need to adjust the dose, so I'll be able to repeat a pain management assessment and see what changes have occurred from the time that she was admitted. I'll make sure that Dr. Crowley is aware and we can make some changes from there, but please make sure that you continue to monitor for any changes and report them.
Morphine's controlled her pain in the past, but she was getting it just as needed, so she's starting to have more breakthrough pain. So we could switch her to regular Q12-hour doses of MS Contin and then between give her PRN doses of MSIR as long as she can swallow the medication. Otherwise, we can switch her to morphine suppositories on a regular schedule and then keep her under control. In the meantime, as you said, we'll increase the Neurontin to tolerance so that it would help potentiate the pain relief. She's already been started on laxatives to help to control possible constipation from the medication.
Okay. Well, based on Mrs. Talbot's advance directives and both Dr. Fraley and one of his colleagues deeming Mrs. Talbot as end stage, I think everyone feels that Mrs. Talbot is appropriate for a palliative care program. Also, based on the information that we've gathered today at our morning meeting, I will be scheduling a care plan meeting for the entire interdisciplinary team. I think it only appropriate to also invite Mr. Talbot as well, being she's so active in her care. Some of the areas that we'll need to address are pain management, of course, and maintaining her comfort and dignity. And other than the pain medication itself, I think we'll also address aromatherapy, some hand massage, and some music that will be provided by activities with the family. We'll also address her overall change in ADL status. And once the MDS is also complete, we'll also care plan anything that triggers on the MDS.
What we need to do when we meet next week is review how the meeting went with the family and also make sure that we make any changes and update the advance directives. Make sure the care plans are updated, and if we do decide that the weights are going to be discontinued, to make sure that the diet restrictions are lifted. If there's any pain management changes, be sure that that's added to the care plan as well, and begin the introduction for the bereavement follow-up, since that's going to be a critical piece for this gentleman as he watches his wife decline in our facility. And next week we'll discuss how far we've come, and hopefully we've made some better choices for outcomes.
Palliative care is an active approach to end-of-life care. Through coordinated staff efforts, suffering can be lessened, and quality of life can be greatly enhanced for nursing home residents and their families. This concludes the video segment on the Palliative Care Team Meeting for Module 6 on Palliative Care. Palliative care focuses on improving the quality of life for persons with progressive, far advanced disease for which there is no known cure. It also addresses psychosocial and bereavement needs of family members. In the following video, the daughter of a nursing home resident who recently died while on the palliative care program discusses how this specialized care helped both her father and her family through the dying process.
If it's possible, could you tell me just a little bit about how your father was active in the community and what he did prior to his admission to the Pines and what things he enjoyed most in life?
My father was a very devoted family man. His children, his wife, all of us were very important to him. He had an active church life. He liked to fish. He liked to hunt in his younger years. But he was most known in the community for his wonderful contracting work. He did marvelous stairways and cabinet making. And of course, throughout the years when his eyesight failed, that kind of put him so that he had some very much difficulty of trying to do those things again, and that's what he loved to do. So he gave away the carpentry business and went into just retiring and fishing and spending time with his family.
Do you think that that was something that could be incorporated into his care when he first came to the Pines?
Well, it was. As you mentioned, they have programs back on the focus unit where the director would plan outings for some of the people that hadn't gotten to a point in their Alzheimer's or their dementia that would reflect them from not going. He was taken fishing a couple times, and even though he had to go in his wheelchair and someone had to help him with the rod and reel, those were the most important times to him, that he was able to go outside and do the things that he enjoyed in the past.
When your father was placed on the palliative care program, what type of things do you feel were appropriate for his care at that time?
Well, like I say, he always wanted to be active with family adventures, and he and my mother would always cook and do canning, and he had a wonderful garden when he retired. And Wilma, one of the girls back on the focus unit that was in the activities, got very close to my father. He even, I think, took to her as a daughter. And she enrolled him in their cooking program, where he just mixed up the mixes and helped to stir. But she told me that he really seemed to enjoy that. And when that would happen, we'd come in to visit, and he'd say that he cooked today. He couldn't remember what he cooked, but at least he knew that he was participating in one of their programs, and it did make a difference.
You noticed the decline with your father, and your family members also noticed that decline, that the care actually changed for him in some ways. When you came in for advanced care planning and discussion of his instructions for care, you brought your entire family with you.
Well, I did want my entire family here because I'm the youngest of 5, and I felt that the older members of the family needed to have as much input on this as I was going to be, even though they had let me be the spokesperson the whole time he had been here. And the staff was very supportive. They went through each one of the items on the advanced directives sheet and made us understand what they meant. There were a couple that were a little misconstrued by my family members because they were kind of worded the same, but they meant different things. And they took the time to explain those so that everyone was under the same understanding. And when the final result was, that all of us did not want anything further done for my father except to keep him comfortable. We wanted his last days to be as comfortable as he could be and without having any further testing. And they made that very easy for us to accept.
Do you feel that the bereavement support that you are receiving now that Dad is gone being somewhat of a help or a hindrance to you?
It has helped me a lot. I've even had several people that became close to us. I mean, I felt that this was Dad's extended family while he was here. And I even had a couple of family members, or the employees here, that have called me because my dad turned 91 shortly after his death. And they knew that I would be kind of in a bad way during that day. And they called me to tell me that they had written on the calendar that today was my dad's birthday. And they wanted to know how I was dealing with it and if I was okay and if my brothers and my sister were all right. And that really made me feel so good to know that even though my father wasn't a member of this facility anymore, that they were still caring for him and had little notes left about him, that they were looking at his birthday as an upcoming event. And that helped us. And then a month or so ago, I received a package from you in the mail that had a booklet in there about how to go through the grieving process. And I understand from our talking that I will receive those throughout the year. And I have shared those with my brothers and my sister, and they seem to appreciate the time and effort that's been taken even after our dad has passed.
If there was anything that you could say to other family members that may be thinking about this type of program for their families when they are coming into a long-term care setting, what would you suggest for them?
Take into consideration what the family member is going to go through. It's hard to let go. It's hard to try to keep, you want to keep them with you as long as you can, but you have to at one point stop being selfish and thinking of your own feelings and also think what they're going through and what their wishes may be, especially if they have dementia and they can't decide for themselves, that you want the best for them. And if their life is not going to be like they wanted it to be, if, like my father, he was just sitting in a wheelchair and just attending some activities, and that really wasn't life. When it gets to a point where we know that the end is near, please just give in and let them go with the most respect and the pain-free, as pain-free as possible.
I'd like to thank you for being able to share that today,
You're
and
welcome.
hopefully that will encourage others to listen to a family member to say, I know where you're coming from, and maybe that I can meet you halfway and see that this is something that would be appropriate for my family member as well.
And I want to thank you too for the care you gave to my dad.
You're welcome.
This concludes the video segment of a family member interview for Module 6 on palliative care.